I would like to take a moment to provide a brief introduction about Pierre Forcher Academy and our Institute of Dental Sciences. Pierre Forcher Academy is an honorary dental service organization founded in 1936 by Dr. Elmer S. Best, and the mission of Pierre Forcher Academy is to recognize and develop outstanding leadership in our profession internationally. SIBAR Institute of Dental Sciences offers BDS and MDS courses in all specialties and PhD programs recognized by Dr. NTR University of Health Sciences, accredited with NAC A++. Now I request Dr. L. Krishna Prasad Sir, Dean, SIBAR Institute of Dental Sciences, to deliver welcome address.
Good afternoon.
Good afternoon, sir.
Yeah, let me convey my thanks to Dr. Rajiv Chud, Chairman of the Pierre Forcher Indian Academy India section, and Secretary Dr. Maya Ramesh.
Thank you, sir.
For allotting us this continuing dental education webinar for our SIBAR Dental Sciences. And of course, today's guest faculty speaker, my good friend Dr. Deepak Muchala, a renowned speaker in all the forums internationally and nationally. The two, by selecting the very apt topic, composite restorations, techniques and trends in the modern dentistry, which is very much useful and helpful for all the young budding dentists and of course all the general practitioners, which will be day-to-day practice. Okay, and of course we are really grateful to the PFA India section for selecting our institution to start this program, and I welcome all our. Today we have assembled here all the postgraduates, interns, and a few of the faculty. So this will be definitely, everybody will go back with a rich, good experience. Okay, about the composites. I heard quite a number of times the Dr. Deepak Muchala sir's lecture on composites and veneering and all, very good. He just, I always feel proud that they are doing excellent work, even though they're very busy in the practice and all, but still there's no compromise in the quality. That's what actually I really feel very proud actually, Dr. Muchala. Thank you very much for selecting this today's topic and accepting invitation of course PFA mainly, and of course our invitation also for being the speaker of the today's program. Thank you very much. Thank you.
Now I request Dr. Rajiv Kumar Chak Sir, Chairperson of Pierre Forcher Academy India section, for opening remarks.
Thank you so much. My dear fellows, colleagues, faculty and students, and audience who have logged on for this program throughout the country. On behalf of the Pierre Forcher Academy India section, I welcome you all to the first webinar of this year. First and foremost, I thank Dr. L. Krishna Prasad, the Dean of SIBAR Institute of Dental Sciences, and Principal Dr. Ramanna Reddy for hosting this program jointly with the Pierre Forcher Academy India section. I'm also grateful to Dr. Deepak Muchala, the past chairman of Pierre Forcher Academy India section, for sparing time from his very busy practice and to share his vast experience and expertise with all of us. As already been told to you, that Pierre Forcher Academy is an international honor dental organization founded in 1936. But I'd like to share with you that the India section was started in the year 1976 and was registered in 1986. The mission of the Pierre Forcher Academy has been to recognize and develop outstanding leadership in our profession. And globally, the Pierre Forcher Academy is currently comprised of about 7,000 fellows, organized into 11 global regions and over 142 local sections. The Pierre Forcher Academy is a service organization of dentists whose members are selected for their dedication to the art and science of dentistry and their contribution to its professional literature. The golden rule of Pere Faucher Academy is placing the welfare of patients above personal aims and desires. The fellowship is only by invitation or nomination and only is limited to ethical dentists. PFA also works to encourage students and senior dentists through annual merit awards and foster advancing the scientific and professional standards. The PFA India section is a unique section in the sense that we have a mentorship program for BDS graduates, which is an initiative of oral and maxillofacial surgery and conservative dentistry and endodontics. So this mentorship program, which is unique in the sense that it is virtually held, 3 months program, and the successful trainees are awarded the mentee certificate from the mentor by PFA. We also have a journal of PFA, which is officially a peer-reviewed journal of Pere Faucher India section, and the journal publishes original, basic, and research articles and case reports. We are honored that Dr. O.P. Kharbanda is at present the chief editor of this journal. So I invite all of you who would be interested in being the fellow of PFA India section to contact me and Dr. Maya Ramesh, our Secretary General, and if recommended by somebody from your institution or any of your colleagues, that will help us accept your application. So I wish you all today a great learning with this program and hope to see you in the subsequent programs as well. Thank you so much.
Now I request Dr. B.V. Ramana Reddy, sir, Principal, SIBAR Institute of Dental Sciences, to give a brief introduction of today's speaker, Deepak Muthala, sir.
Is Ramana talking?
Sorry, sir, there was some technical glitch, sir, actually.
No problem, absolutely.
Respected Dr. Rajiv Chik, sir, Chairman, Pere Faucher Academy, India section. Dr. Maya, Secretary, Pere Faucher Academy, India section. Dr. Krishna Prasad, sir, Dean, Department of Dental Sciences. Dear friends and students, it is my great privilege to introduce today's speaker, Dr. Deepak Muthala, sir, a renowned expert in the field of dentistry with an exceptional career spanning over 4 decades. Sir is a graduate of the prestigious Government Dental College and Hospital in Mumbai and holds a master's in creative and aesthetic dentistry from Baylor College, Texas, United States of America. He furthered his from Goethe University, Frankfurt, Germany, and completed a certificate program in occlusion at the Dawson Academy in the United States. Sir made significant contributions to the dental community, serving as a treasurer of Indian Dental Association head office since 2002, and as an associate editor for the Indian section of the American Dental Association Journal. He is a founder member of the Academy of Cosmetic Dentistry of India and the Indian Academy of Digital Dentistry. In addition to his private practice, which has focused on restorative, cosmetic, and implant dentistry for the past 40 years, Sir is a respected member of several international organizations, including the American Dental Association. He has also served as a past chairman of the Perry Fosher Academy India section and the chairman of the International Digital Dentistry Conference, a position he continues to hold for the 2024 conference. Sir is a sought after educator, delivering lectures to over 3,000 dentists annually, both in India and abroad. Notably, is the only dentist in India to conduct a year-long fellowship program in restorative and aesthetic dentistry in collaboration with the Maharashtra University of Health Sciences. In his ongoing commitment to social cause, Sir has been actively involved with Specially Abled Children's School in Mumbai, providing free treatment and consultation for the past decade. He also holds numerous publications and scientific presentations at both national and international forums. So we are honored to have Dr. Muchala sir with us today, share his insights and expertise in this session. Please join me in welcoming Dr. Muchala sir. Sir, please.
Thank you very much, Ramana, for those kind words. At the outset, thank you very much, my dear friend Rajiv, President of the P.F. Oshad Academy India section, and Dr. Maya, Secretary of the P.F. Oshad Academy India section. It's an honor to be back with PFA, even though as someone to share the expertise on a little bit on some topics that are very dear to me also, and it's something which I think it's being used by everyone on day-to-day practice. So I think that under the leadership of Dr. Rajiv Chuk, PF Oshad Academy has really progressed considerably, and I'm sure that the amount of fellows that have been installed during his term, I think probably that may have been a record. I'm sure it must have been a record. Rajiv, is that true? The number of fellows that you are muted.
I said I'm going to induct new fellows this year. Last year we worked hard to enroll in Dr. Garg's term, but this year we intend crossing that number.
Oh, great, great, great. Congratulations on that. It's really something nice. And even though, as I was the chairman during that difficult time when it was COVID time, but still we managed to do a lot of things during our term also. And I think that the torch that has been now gone from me to you, I'm sure that you'll take it to greater heights, Rajiv. Thank you very much for having me for this inaugural online function or as an opening batsman. And I'm sure that there'll be many more that you will be doing during your term. SIBAR Dental College is one of my favorite institutes, and Dr. L. Krishna Prasad, a really close friend of mine, and the kind of transformation that he has done to this particular college is really commendable. And I think that his values, his commitment to ensure that every student who walks into that institute, when he or she gets out of the institute, goes with great memories, great learning, and that is what he has been doing it since so many years. So, LKP, kudos to a big round of applause for what you're doing for SIBA. Really, it's fantastic that and it's so I feel so proud to be considered as your friend. Thank you very much, LKP. And also along with that, we have Dr. Ramana Reddy, who's the principal. Very silent, I would say a worker, and I will also say a silent killer because the amount of work that he puts in, I have seen him close at work in IDA in so many projects. And the moment something is given to him, rest be assured that it will be done within no time and done absolutely where you don't have to even look at it again. So Ramana, thank you very much for all the work that you're doing in SIBAR and outside SIBAR and IDA also. Some amazing work we've been doing together in the OHO along with the FDI, which is really commendable. I think we have some other people from PFA also present today. None other than another friend of mine, Dr. Ravindra Singh, who's been a past president of IDA. Dr. Ravindra Singh, thank you very much for being here today. I really appreciate that. And I think I saw Dr. Kharbanda entering. So, Dr. Kharbanda, thank you very much for being here for the inaugural session of this year's PFA online programs. And what can I say for Dr. Kharbanda? He's a legend himself, and we're a very down-to-earth gentleman. And the journal that he's bringing out in PFA since so many years, every time when I meet him, he says, "I want to resign from post of the journal," and I don't think anyone wants him to resign. So I'm sure that we'll keep him for many more years in PFA. Thank you very much, Dr. Kharbanda, for being part of this particular program. So I'll just start sharing my screen and we'll start with our lecture. Okay. It's something which is, as I said, very close to me. Optimizing composite restorations, techniques and trends for modern dentistry. So when we talk about aesthetic dentistry and when we talk about composites, achieving high aesthetic results, what our goal is for achieving high aesthetic results. It should be predictable. It should be simple. It should be consistently. It can be done easily. And that should be the central challenge of aesthetic dentistry. In fact, I feel that in cosmetic dentistry, one second. I'll just minimize this. Yeah.
Your screen is not visible yet.
Not yet?
No.
I've already started sharing it.
Screen is visible. Your PPT is visible, sir.
It's visible, no?
Yeah.
Okay. So should I continue that? LKP, Kramana, is visible out there for you all?
It's visible, sir. It's
Okay,
visible.
okay. Okay, great. So, as with anything in dentistry, okay, thank you. As with anything in dentistry, it's extremely important to remember that cosmetic dentistry is a branch which was an offset in the 90s when everyone wanted to start looking good and start having great smiles. So the principles of all the fields of dentistry were combined together. So there are specific principles and methods like any other procedure. So let us take this mystery and guesswork out of this particular subject, which is so common. So I'll just share three slides with you all, and I'm not going to talk about it. It's just going to be in the screen for a few seconds, and then I just want you all to gaze at it carefully and try and understand if you all can make out whether any kind of restorative work has been done, and if it has been done, how to achieve that. So as I said that it's extremely difficult for me in this short period of time to really get into the nitty-gritty of how you're supposed to do it, but I'll try and highlight things which will make it extremely important for you all to understand that it's not difficult to do what you just saw on the screen. There are those three slides that I shared had some amount of restorative work which was done. How to achieve that and how to ensure that whatever is done in along with everything that is required to achieve that result. So the first most important aspect that one needs to talk about is the dental operatory light. A lot of people do not even talk about it. According to me, the dental operative light is nothing as big as wearing loops. If you do not have good light and you cannot see properly, obviously you'll not be able to do your work properly. And we all know that the oral cavity is dark in a secluded field. And that's the reason why lights become an absolutely integral part of good dentistry. So better visibility means better treatment options. So it's as simple as that. And so for any task, the eye can respond effectively if there is enough light. And if the light is properly distributed and if the appropriate color correction is provided, then you will be even able to check this, uh, see the color of the particular tooth. Because as when we talk about composites, we know that one of the goals for us is to try and have uh, it's extremely important that the color match is absolutely perfect so that you can have restorations which are absolutely seamless and no one can come to know where the restoration is and where the tooth starts from. The next very important aspect that each one of us should have in our practices is dental loops. It's something where people, I've been using dental loops since the first day of my practice. And people earlier used to say that your eyes get spoiled and that vision is affected. I am a testimony standing and sitting in front of you with wearing loops of different magnification for almost about 45 years that in practice, 40 years in practice, and before that in other aspects where I've been using the loops. So it's something which I think each and every one should have, whether it's in college, whether it's an institute, or whether it is in private practice. And data suggests that every dental professional is also at risk because of the occupational hazard of the way we practice, how our position is, how our shoulders are, how our back is, and we are so much at risk for occupational musculoskeletal injury. And to prevent that, loops helps us to sit erect and helps us to work for long period of years that we have in our practice. Wherever you may be, whether you are in college or whether you're in private practice, it's absolutely a must that posture becomes a very important aspect of the way you practice. That will really help you to, and if you are healthy, you will be able to work better. So we all know that the principle of dental loops is so simple. Bigger, if you can see bigger and better, then the end result will be definitely better. Hence, maintenance of correct posture is vital for dental professionals, and dental loops helps us in facilitating this. And one can work for many more years without any musculoskeletal injury, as I just mentioned. Another aspect in restorative dentistry, which is extremely important and which is not given too much of credence, is occlusion. Restorative dentistry, as we all know, is built on a foundation of solid occlusion. If the occlusion is not addressed before we start the procedure, then no matter how good your margins are, how good your shade match are on the restoration, the patient will ultimately either chew it up or spit it out. That means it's going to be a failure. Hence, it's extremely important that a thorough occlusal examination is a must before initiating any restorative work. Whether it is even a simple class 1 restoration, that's the procedure that I follow in my practice to ensure on that tooth what is the kind of occlusion that is present and also examine the overall occlusion and if there are any things that need to be corrected before you take up any restorative work. So correct diagnosis along with treating the etiology will help us to achieve the good and long lasting results in our restorations. So never forget about the function because function is what creates some of the biggest successes and also failures in dentistry. So if this part of the restorative part, that is the occlusion part, is not addressed by you, I can assure you that the results that you will have will not be very satisfactory. No one likes a failure in their practice, whether you are at the hospital, whether you are at a clinic, wherever it is. A failure is something which we do not like it at all in our journey in dentistry. So these are some of the slides which I put up about the occlusion where we needed to have some kind of something to be addressed about. Another very important thing, and this I must now insist on, whether is with Maya or whether it is with Dr. Elkepi or anyone, please start having more lectures on anatomy, and please start insisting on each and every student, whether it is third year, final year, intern, postgraduate, to ensure that the learning process of the anatomy of the tooth is understood by them in such a way that when you look at any tooth, it's something there where you should be able to diagnose from there what part of the anatomy is missing from it. God has made teeth in such a way that every part that He has given is extremely important. Whether you talk about the marginal ridge, whether you talk about the fossa, whether you talk about line angles, everything that God has been made with a purpose. So, extremely important that each and every one of y'all learn anatomy. This is one particular aspect which is going to not only help in restorative dentistry, but in dentistry in general, to ensure that you have great results in whatever you do, whether it is restorative, implant dentistry, prosthetics, complete dentures, anything that you are going to be doing, this is going to be central to understanding the final results. So learn dental anatomy, learn to look at teeth from all different angles, not just from the frontal aspect. Look at it from the occlusal aspect, from the side view, from the palatal aspect, from the lingual aspect. Extremely important that every aspect of the tooth that has been lost is replaced exactly the way that God has made in that particular patient. I mean, I've seen so many cases where if it's a class 4 fracture or anything, the lingual aspect, they say that, oh, but the patient cannot see. I said, but it's in function. That's the most important aspect of the anatomy or the restoration on the lingual or the palatal side, which plays a vital role in the occlusion. So if you're going to give a flat palatal surface without any line angles or any fossa, it's going to be detrimental to the longevity of that particular restoration. So learn the anatomic form of the tooth. Restoring the normal anatomic form of an individual tooth should result in correct relationship not only with the adjacent teeth, but also correct relationship with the opposing teeth. Correct buccolingual contour so that they can maintain good oral hygiene, and your results of the restoration will be such that it has good aesthetics, and simultaneously it stays for a very long period of time. And people keep on asking me, Doc, how long do you think that a composite should last? I said, as long as you want them to last. I have results in my practice, as Dr. Ramana said, that I've been in dentistry since a very long period of time. I have records. Like a simple example that I'll give you is there was a young gentleman, a Sardarji, who walked into my practice uh, about 4 days back, and he, he's now almost about 30 years, 35 years old. And he says, Doc, do you remember that when I had come to you first? I said, yes, I remember. It's been a long time, but I don't remember exactly. He said, the first time I walked into your practice was when I broke my central incisors, two central incisors. And that was somewhere in the 95 or 98 or something like that, he's mentioned. And he came for some other carious lesions. And he says, Doc, that front tooth that you had done is still there in my mouth. So can you believe it? I have, in fact, if I should have added that particular slide because we just took photos for his other fillings. So I wish I could have put that up. So that was done. It was a class 4, almost half right central incisor, which was done by me in 97. And this is 25, 28 years. It's a long period of time for a composite to last. No doubt it's not a load-bearing area, we all know, but still even in anterior region, aesthetic becomes a very important aspect when you want the restoration to last for a very long period of time. So as you can see in this particular slide, that the last point that I've added is the aesthetics. And that is the kind of credence I give to other things before aesthetics. Aesthetics, that means if it is lifelike, has no meaning if that restoration or the filling is going to last for a very short period of time. So you need to understand the form of the tooth, extremely important. When you, as an artist, as a dentist, are going to recreate restorations in composites, you really need to know the three-dimensional picture of the tooth that you are going to be restoring. Some photos to show how beautifully we have restored the anterior restorations in composites. These are veneers that have been done. But I have taken these photos from different lights to make you all understand the translucency, the opacity, the anatomy, the line angles, the form, everything for you all to understand that how best we should be able to recreate our restorations. Another extremely important aspect that one needs to take care of when we are talking about composites is adhesion. It's extremely important to understand and learn about the current techniques, especially of dentine bonding, as it is one of the most difficult and challenging substrate where you can bond the composite to the natural tooth structure. And these are the following points that you all should take into consideration. I don't know, I'll be in a position to get into the details of all the adhesive materials that are available in the market. As I said, that it's impossible beyond the scope of this particular lecture. But I'm sure that Dr. LKP is so keen for me to come to SIBAR. I'm sure I'm going to be there, Dr. LKP, I promise you, very soon. And we can have something going on, whatever that you all want to learn as far as whether it's to do with direct restorations or indirect digital part of it. I'm there to help you because I'm so close to you, LKP, that anytime you call me, I'll be there. So the primary mechanism of adhesion is on enamel and dentine. So there are a lot of different kinds of adhesives which are available in the market, and we started from the first generation, and now we have reached the 8th generation of the adhesives. The fourth and the fifth, the fourth is considered as a gold standard in the adhesives that are available in the market. I used to use that for quite some number of years, and almost since the time when its availability started reducing, but I still love the fourth generation of the adhesives that are, it's a 3 bottle. The sixth and the seventh generation are the self-etched ones. And I'll talk about the eighth generation, which is there, which I have put up another slide for. So you have to know the advantages and disadvantages of all the adhesives that are available in the market. Another very critical point which I need to address is that every time that we buy something, we just hear it in some lecture, or we've learned it from someone, but how many of y'all take the time to remove that paper which is present, which is supplied by the company, to know the details of the product that you're going to be using? We open the box, throw that paper into the dustbin without even reading the pros and cons, the advantages, disadvantages, how to use it. Everything is similar, but every company may have something which is a little different. So extremely important to read what is being supplied by the company and read it to ensure that anything that is besides what you all have learned is going to help you to achieve results as whatever that you're using. And here in adhesive dentistry, and the adhesives that are using, extremely important for you all to know. So there is adhesion to enamel, which is a very simple process. That means you apply phosphoric acid on it, and it removes the calcium from it, the mineral content. It etches well. You have a dry surface. The resin flows into the spaces that are created by the etchant that you have been using. And then it forms the strongest bond that is possible on the tooth. So please remember, there are some mics which are open. Please, that is disturbing me. Can you all be muted on that, please? Thank you very much. Another thing extremely important to remember, that whenever you're doing, whether it's restorative dentistry or whether it's prosthetic dentistry, still there are a lot of mics which are open, please. Can you please be sure that everyone is muted? Extremely important to understand that try and save as much of enamel as possible, because the bond strength to the enamel is by far the greatest. What God has made enamel, as we all know by now, that it's stronger than even the diamond that is available in the market. It's something where, if you notice, even after our teeth wear off, a lot of people you all must have seen who are in their 80s or even in the 90s, and so much of enamel which is still present. So you can imagine that whoever the creator is has given us something to protect our teeth, because our teeth are for life, and to ensure that this enamel also lasts for a longer period of time. So try and be very conservative to ensure that you keep as much of enamel, because the bond strength to enamel is by far the greatest compared to even dentine. Bonding to dentine is really complicated. It's a very technique sensitive process. You have to ensure that you do not over dry the dentine. In fact, when I teach about dentine bonding, there are almost about uh, 20 slides which are there, which has everything about that. Is extremely important. But unfortunately, I said that it's impossible for me to talk about it in this particular lecture. So most important thing is that even though you have adhesives which are now available, wherein they incorporate the smear layer and you get a good effective bond, but I prefer to remove the smear layer, because the cleaner the surface, the more open the tubules and more chance for the adhesive to go into the tubules and the peritubular dentine, to ensure that you achieve good bond strength to the dentine, because bonding to in dentine is by far one of the most crucial aspects for the longevity of the restoration. The surface is hydrophilic, and that's the reason why it must be kept moist. If you do not keep it moist, it will collapse. The intertubular dentine will collapse, and the adhesive which goes into the fibrils which are intertubular will not be able to intertwine with that, and you will have less bond strength with the dentine. And also the amount of time that you put the etchant on the dentine is very critical. And it is critical in the sense that when I take the courses, I ensure that everyone brings a timer, because it has to be by the clock. The amount of time that the dentine, the etchant should remain on the dentine should not be more than 15 seconds. That is by the clock. Anything more than that is going to affect, because we do not want to over etch the dentine wherein the adhesive may not be able to flow, and also keep that space open for the microorganisms to make pathways for it to go very easily into the pulp. And that's the reason why it's extremely important that you go by the clock. And also, we have to ensure that it is completely sealed, because this is the area, this is the part of the tooth wherein once the bacteria encroach into the dental tubules, we know that the day is not too far when that particular tooth will go into from a restorative to an endo perspective. So let's talk a little bit about the eighth generation of the adhesives that are available in the market. There are many universal adhesives which are available, and they use a phosphate which is called as 10-MDP. That's the only thing that you have to remember as the primary adhesive functional monomer. 10-MDP is the most hydrophobic of the adhesive functional monomers which is available in the market. It should be noted that the 8th generation universal adhesive should not be confused with the single bottle 7th generation self-etch adhesives that are incompatible with the self-cure and most dual cure resin cements and indirect restorations. So ensure that the adhesive that you are using is being used for the right purpose, for the right area, and also to increase the longevity of whatever you are doing. The 7th generation adhesives are more susceptible to hydrolysis and bond degradation over a period of time. And MDP is one of the monomers that enables a universal adhesive to be used with any kind of etching techniques that you may be using in your practice. So after talking a little bit about the adhesives, and then when I started with the occlusion, and then when I started with after that, the anatomy, and then I came to the use of the adhesives, now it's time to talk about the preparation designs for the composites. Do we follow the same principles that we have learned by G.V. Black? When I talk about the preparation design for composites, I always pay my homage to G.V. Black because what we have learned is unbelievable. And I also jokingly say that when I talk about the preparation design for the composites, probably G.V. Black must be turning in his grave because we have to forget the principles that we have learned of preparation design for silver amalgam restoration. The most important thing that you have to remember as far as design preparation for composites is concerned is first and foremost is that it should be restricted. First, remove only caries. Then you decide on the outline form of your preparation. You have to ensure, because these are adhesive restorations, that you be as conservative as possible without having any failures as far as the thickness is concerned, without having any failures as far as fracture over a long period of concern. So all that also needs to be taken into consideration. Conservative does not mean that those factors are not taken into consideration. There is no extension for prevention as far as preparation designs are concerned. As far as the class 2 is concerned, should we break the contact point or should we not break the contact point in composites? That's a question which is asked always by every participant when they come to learn from us. See, breaking a contact point is not exactly important unless and until that area that you are addressing has got secondary caries or has got caries. Then and only then you break the contact point. Otherwise, there is absolutely no need for you to extend that preparation onto the buccal and the lingual or the palatal area to get that wide box that we have normally seen in our silver amalgam restorations. The buccolingual dimension of the preparation also is extremely important, especially when we are talking about a class 2 restoration. And that is that the occlusal extension should be at least 1/3 the width of the buccolingual width of that particular tooth that you are treating. The internal line angles have to be absolutely smooth. There is one thing that you'll have to remember as far as dentistry is concerned, that in dentistry, whatever you do, every material that is being used in dentistry does not like sharp line angles or sharp edges. That is the first line of failure that will start occurring because the amount of stress that is accumulated in whether it's a composite or whether it's a ceramic in those sharp line angles will be transmitted laterally, and then you'll have a fracture of a composite or you'll have a fracture of an indirect restoration. Do we give bevels on a class 2? On the occlusal surface, bevels are a total no. The only area where you require to give uh, bevel is in the floor, and that also if your preparation, that is your box, is above the CEJ. So it's extremely important that you give your bevel only there. There are reasons for it. If I get time, I will talk about that also. And also the width of the proximal box. How wide should the proximal box be? Should we have a normal proximal box that we have learned about and when we talked about the silver amalgam? No way. As I said, the caries will dictate the outline form of your preparation. The depth also on the occlusal surface, at least the depth of your round burr. So that's the reason why whatever you all learn in dentistry or whatever you all do in dentistry, please start measuring them in millimeters, because in dentistry, everything is in millimeters. Unless and until you know how wide your burr is, what the cutting edge is, what is the height of that, you will not know how much you are cutting. It's extremely important. Does anyone know that the tip number 11 TF burr that we start our preparation in indirect crown cutting, what is the width of that tip that is there? Start measuring that, because the width of that tip is barely about 0.5 millimeter. And as you go up and as it is tapered burr, it'll be almost 1 millimeter. Same way, a straight fissure burr, a medium straight fissure burr, which you use for your class 2s in an air rotor. What is the width of that? It's approximately about 1 millimeter or 1.2 millimeters. So all this is what you all have to now start addressing and learning for to be more precise in everything that you do in dentistry. So start preserving as much of enamel as possible. So coming from the posterior to the anterior, what is the kind of preparation that we'll require for the composites? For the anterior, you require at least minimum 0.3 millimeter deep chamfer. Can you understand that? What is the amount of, that's the first question I ask. What is the amount of thickness of the enamel which is present on a central incisor or on a lateral incisor? Tomorrow, please start doing that. Take a central incisor, strip it halfway, measure the amount of enamel that is present in the cervical, amount which is present at the middle third, and the amount of enamel which is present at the incisor edge. That will be a great learning curve for you all to understand how you all have to address composites, because composites, we are going to be learning about the layering technique wherein you have dentine shades and enamel shades. Unless and until you all don't understand what is 0.5 millimeter, how it is 1 millimeter, and you all don't understand colorimetry, it'll be impossible to create lifelike restorations. So on an anterior restoration, you just require a 0.3 millimeter deep chamfer or a bevel in a class 4 or a class 3, 2 to 3 millimeter long bevel from wherever the fracture is or wherever the class 3 is. Scalloping of the bevel. What do I mean by scalloping? You need to have the Mumbai skyline bevel or the New York skyline bevel, which is, up and down, up and down. You see all those high rise buildings. That's how the bevel should be. And at the junction of wherever you're given that 2 to 3 millimeter long bevel, at that junction, you have to have a 0.5 millimeter gingival bevel if at all your enamel is um, uh, above the cervical region, or if it is subgingival, then you don't have to give a bevel over there. So the idea of giving the starburst bevel or the skyline bevel is to ensure that the composite that you place in that particular region, there is a refraction and reflection of light which will take place from them, and the junction of the composite to the natural tooth structure will not be seen, and hence you will have a restoration which is absolutely lifelike and merges with the natural tooth structure, where you will not know where the tooth starts and where your restoration starts. Addressing the lingual palatal margin, extremely important for you to know where your lower incisors are hitting onto the palatal surface of the anterior teeth when you're doing a class 4. If it is exactly at the junction of the palatal area where the tooth is fractured, you have to ensure that you take your bevel at least 2 millimeters beyond that junction. Otherwise, the forces that will be addressed exactly at the junction of the fracture and the lower, even during normal occlusion, is going to bring about a fracture of the anterior restoration, especially a class 4. So your margin should be free of occlusion. That is what I meant by extending on the palatal surface to the or bevel on the palatal surface. Another very important aspect that you need to understand is something in the posterior region is called as a C factor. Now, what is a C factor? C factor is nothing but the amount of the ratio of the bonded to the unbonded surface. And in a class 1, it's the ratio of the bonded surface to the unbonded surface. As I put up this class 1, you can see that the ratio is 5. That is the highest in a class 1. And anyone who has done a class 1 and says that I have not had failures as far as sensitivity or fracture, either the patients are not coming back to them or going to the neighboring dentist, or they are telling a lie. Class 1s are one of the most difficult restorations post-operative I'm talking about. I'm not talking about the placement of or doing it up is not so difficult, but the post-operative aspect. A lot of people come back with post-op sensitivity because the most important aspect, as you can see, there is an arrow which is there on this particular slide, which is drawn from the buccal region going onwards to the lingual region. If you put that arrow in the center of the tooth, that means that the mesial marginal ridge here, going right up to the distal marginal ridge, exactly dividing the tooth into two, ensure in a class 1 and a class 2 that you do not cross this particular line while placing your composites. You have to first finish this aspect and then you have to take up the lingual, or if you are doing the lingual first, then you finish the lingual and then come to the buccal. Because the amount of polymerization shrinkage that occurs if you put a lot of material together is going to bring about fracture of the restoration, post-op sensitivity, marginal leakage, secondary caries, and finally failure of the restoration. So as you can see from this particular slide, that when you come to class 4, the C factor ratio is just 0.5. And that's the reason even if you add in bulk over there, even if you add it in one layer of the facial surface, it's not going to hamper in any way as far as the polymerization shrinkage is concerned. So this is the kind of bevel that you have to give for a class 4. As you can see, it's almost about 2 to 3 millimeters. And you can see that starburst, where I've done this scalloping at the end of the margin, which is going to help merge the composite to the natural restoration. Preparations, conservative preparations of class 2s and a wider preparation depending on the amount of caries that is present, but still much, much less compared to the GB Black principles that we have learned. Two factors directly influence tooth coloration, that is dentine and the enamel. We all know that what is it that gives color to the tooth? It's the dentine which gives color to the tooth, and it's not the enamel. Enamel is translucent. Enamel acts like a fiber optic structure. Like, like we put those fiber optic line all over. It's something similar to that, those fiber optic lines through its rods and into the underlying dentine. So light passes through the enamel. Whatever the color of the dentine will be reflected back, and that is what is you're going to be noticing it as the color of the tooth, whether you call it as an A shade, B shade, C shade, or a D shade, whatever it may be. So the color is mainly obtained from the dentine and it's not from the enamel. So the internal color contributes greatly to the depth and the vitality of the natural dentition. Because light reflects, refracts, and absorbs in different areas of the tooth, it is important to use composites that mimic the natural tooth structure. So in recent years, there have been numerous composites which are available in the market. Composites which are available in the market in different shades, translucencies, opacities, and effects that, together with the innovative layering technique, placement technique, make it possible to fabricate restorations that emulate the polychromatic variations and optical characteristics present in natural tooth structure. And the final aspect, which you cannot miss, if you miss this particular aspect, then you have done injustice to the patient. Finishing and polishing, you have to spend as much as time as you have done to in placement of the composite, in giving the right anatomy and right finishing. That is what is going to make your restoration last a longer period of time. So there are three things that you'll have to understand as far as finishing and polishing. Finishing is method of surface treatment. Polishing is to make or become smooth or glossy by rubbing. And luster is to give gloss and shiny surface or brilliant glaze, or as you can see, like on pottery or like in porcelain, the glaze that you see. So these are the three steps that finishing is giving the form. Polishing is to rubbing it and making it smooth. And luster is the final gloss that you give. These are the three steps and these are all the things that we use to ensure that we get absolutely fantastic finish and polish to the restorations. We use a 12 number blade to remove all the excess in the class 2s. For your interdental finishing strips, there's so many things which are available in the market. Polishing paste on the upper right corner. Enamelize is one of the unfortunate, it's not available here. It was available once upon a time. Then silicone cups in different shapes, different companies, interdental polishing system, which is called as Profane, everything I have in my practice, which helps me to give the final result that I want. The finishing discs are used to give the rounding of the marginal ridge in the class 2s. These fluted burrs are used to give the shape of the occlusal surface. Then this is for the polishing that is used. These are the silicon cups, flame shape or cup or disc that is used. Now, this slide that I'm putting up on the screen is to make you understand this is what I do to make people learn when they come to learn composite. This is an extracted tooth on which I did a composite veneer, put different shades, did staining, added blue tint to it, add the incisal edge. I have added a white tint. You can see that I have given a hypocalcified area on the upper left incisal edge by putting that white tint. I have added the hue of the cervical region where the enamel is very thin and the color of the dentine is in more, where I've added a little bit of uh, yellow over there and different colors which we use. Now, if you look at this particular tooth that has been recreated in composite, I don't think if I would have told you that this was a composite tooth, you would have really believed that this is something which has been recreated in composite, and whether composite can really be highly polished like this, which can last for a. And this is the kind of result I get in each and every case that I do in my practice. Why do you think that this particular veneer looks lifelike? There are many reasons for it. First and foremost, it is polychromatic. Second is the anatomy. Third is the form. Fourth is the texture. Everything that God has made, we have to try and recreate for it to make it lifelike in appearance. And that is what we are here to learn and talk about. So, composite success is dependent on patient selection. You have to ask them about their oral habits, the number of teeth that you have to do, the bite, that means the occlusion, whether the patient is a bruxer, what is the kind of a diet, with a high risk diet, if the patient is constantly on soft drinks or a lot of sweets or sugar that they are taking. And so you have to assess, you have to do a caries risk assessment before you get into any kind of treatment, to let them know that if they are not going to compromise on what their habits are and you are going to be doing something, obviously this particular restoration is not going to last for as long as you would want to, but it will come back as a failure in a very short period of time. You as a dentist, have you been trained in this? What is the amount of experience that you have gathered in this? Are you using all that I have mentioned as far as dental loops, the right lights and everything for you all to give the kind of results that you're going to still see further? And the tooth, the location, the number of restorations, the lesions, previous trauma, habits, sclerotic dentine, everything has to be taken into consideration when you're doing. So for me, when a patient walks into our practice or wherever I'm treating, it's not that I look at the patients who has come. No doubt, I obviously ask the patient what the initial problem is. I look at that particular tooth, but I look at the patient in toto, everything that we have talked about. And then finally, it's extremely important you learn about isolation, the preparation, isolation. No doubt, rubber dam is absolutely a must if you really want to have good success in restorative and prosthetic dentistry. And also in composite success, you need to talk about bases or liners. Do I give a liner? That means, do I give a lining before I do my composites in a posterior region? No, I don't believe in that philosophy. I believe that a composite, however closer it is to the pulp, is not what is going to give rise to non-vitality to the tooth or the pulp being affected. It's the margins, it's the ingrained, it is the amount of bacteria which will go into the microscopic spaces that may have been left behind, either because of the adhesives or selecting the right adhesive, the adhesive application technique, the curing light. How many of you all have a light meter in your practices or in your colleges? Do you all check whether your light that is coming out of your light is sufficient enough to cure your composite? It's extremely important to have that. Unless and until you have that, you have to regularly check your light. It's not like that when you bought a light, you bought it in 1960 and in 2025, that light is going to give you the same kind of service. You need to replace the bulb, like in our houses, the same way you need to replace the bulbs in the light cure units. Composite selection, extremely important. What are the kind of composites we'll use in the anterior and the posterior? No doubt now we have all the restorative materials that are available, which are now universal, where you can use it for the anterior as well as the posterior. Learn the layering technique where you start with the first layer, that is the flow, then after that is the dentine shade, then the enamel shade, and if at all that particular tooth has some translucent shade or a bleach shade, you apply that. Learn the finishing and polishing technique and think about the occlusion, then and only then you'll be able to bring about great success to your restoration. So let's rush through some of the cases before I end so that for you all to understand how important it is to get that lifeline. Caries removal, that's about it. No breaking. The beautiful transverse ridge that is present, which we were already taught, earlier, that if you have two dots, one dot in the mesial and the other, just cross, remove that huge thick enamel which is present. That is the one, that is the transverse ridge which is going to help you in the long run for the tooth to remain in the mouth for a long period of time. So just remove the caries, and with the layering technique and the finishing technique, you can achieve. See the kind of transverse ridge that was recreated for this, a kind of a class 1 compound. Let's now jump. This is the case which I had put up in the first 3 slides, as I said. Now, this is a molar which has been replaced. The reason of putting up the post before putting up the pre is wherein I don't know whether you all can identify exactly where the composite is and where the tooth is. This is one particular case where I was treating a union minister, and I wanted to impress him, and then I did all this, and finally, I showed it to him on the computer screen, after doing it, and he says, "Deepak, what's wrong with you?" I said, "Sir, what? I completed your work. Can't you see this? It's such a beautiful thing." He says, "What beautiful? You've not even removed caries. So please remember, if you want to stain your composites with your brown or try to imitate these lines of the caries in the grooves, please inform the patient beforehand. Otherwise, you'll be in trouble like me, where I had to remove that and redo the last layer to ensure that this particular." But you see the beauty of the layering technique and the placement technique and how beautifully. Now I'll show you the preparation. So this was the class 2. Now you compare it. Look at the marginal ridge on the mesial side. How beautifully we have been able to create everything with the triangular fossa, where the marginal ridge should be. Where is the occlusal embrasure of the marginal ridge? Everything, even the buccal silver filling was removed, and you can see, if you notice it very clearly, I have even made those grooves which are normally present onto the buccal surface. Everything has been made with a purpose, so please try and recreate that. Can you all guess what is it, whether it is composite or whether it is natural tooth structure? Now, this is a restoration which has been done with composite restoration, and I'll show you on the outline form with my finger. It starts from here. This is the whole cusp which has been replaced. This marginal ridge going right here, 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 here. That's how huge this composite restoration, and see the beauty of building it up, making it lifelike, and creating. It is looking good because it has got anatomy, because it has got polychromacity, because it has got everything what should be present in a posterior tooth. I can keep on showing a lot of cases to you all. I'll rush a little bit. I think I'm not too good with the time. I think I started at almost about 2:15, 2:17. So we still have another about 8-9 minutes. Now, this particular case is extremely dear to me. Now, if I put this up, and normally when I ask a question to everyone who's present listening to this, and what is your line of treatment for this? And let me tell you, my dear friends, that 90% of the people sitting out there would just say root canal treatment, post, and a crown, which is really sad because this is a vital tooth. use your imagination, use your ability to understand that we have less amount of tooth structure which is left now. This was an old silver filling. As you can see, the amount of silver, color of this cusp, silver has leached into the cusp. That's the reason why the color is a little grayish in that particular area. So I convinced the patient. I said, see, this is a vital tooth. Let us build this up directly with the composite restoration. And this is what we did to the final restoration in one sitting. As you can compare it, you can see this gray color on the tip of the cusp, which is also present on the pre, which is present, but how beautifully we can recreate it by understanding the principles of adhesion, the principles of layering technique, the principles of occlusion, the principles of the light, everything that we need to understand as far as direct restoration is concerned. And this is there in the patient's mouth for now 8 years. So basically, we are delaying the whole process. I know that one day this particular tooth is going to become non-vital. When is the question mark? And that's what that question mark is what I want to delay in this particular patient. Another case of a very conservative preparation in a class 2 which has been done. So let's jump from the posterior to the anterior restorations. A class 3 restoration, people are so scared of taking a labial approach. If you are very good with and you master your composites, you will not be scared. But this is the kind of bevel that you need to give on your class 3 or a class 4. So first you put and this is after giving the same kind of a texture which is present. This is a 6-year follow-up. It's written as 4-year, but you can see that the amount of wear that is present, if you see the previous slide, see the kind of striations that were given because that's what the patient had on the contralateral tooth. So over a period of time, the composite is worn up after 4 years, and you can see that it still looks the same. A little bit of staining onto the incisal edge that you can see is because the patient is basically a pan eater and a tobacco eater, but still we have managed to make this particular composite survive. That's because of the finishing and polishing technique that was. So what we need to do is over here, when you can start seeing the margin of the bevel that you can see right here on the class 3, that's the time when you just need to etch that particular area, add either a translucent or the shade of the enamel that is present over there, and just not redoing the whole thing, but just patching it up, and you can even do and still last for a long period of time. Another class 4 wherein we have added, if you can see on the contralateral tooth, on the distal edge, you can see the hypoplastic spot. Now I asked the patient whether he wants it to be done by giving him a smile designing and doing veneers and all. He says, Doc, I'm okay with my smile. I don't mind those white spots. So to make it more lifelike, I had recreated the life of the hypoplastic spot on the class 4 that is there on the left central incisor by adding that white tint. And if you see the lateral incisor, the class 3 and the class 4 on the facial surface, see the amount of hypoplasia which is present on the contralateral. And the same thing I've tried to recreate on the lateral incisor to make it more lifelike in appearance. Other class 4s. This is one thing which I really hate when people do not know. This is something lack of knowing adhesive dentistry, and they feel that what they're going to be doing is not going to last. So they do a joint restoration in the adjacent teeth. This is one of the worst things to do in dentistry. And obviously, it's bound to lead to secondary case. Like you can see, it doesn't look good. It's got secondary case of the palaces, and we restored it with composite. Now, this is a dentist who walked into a practice. If you can see, she's got a class 3s and class 4s done somewhere else. Look at the gingival condition, inflamed, highly inflamed. So first we put her on a perio program where we just did plain scaling, waited for almost about a month for the gingiva to heal, removed all the old restorations, and we transformed the smile from this. She was ashamed. You won't believe. She said that even in my preschool days, that means when she was in the 3rd year and final year, she would put a handkerchief in front of her mouth and she would not smile because of these ugly restorations that she had in the anterior region. And we transformed it from this to this. See that this was also another slide which I had put up in the earlier time for you all to know where the restorations are. See how beautifully we can recreate with saving as much of natural tooth structure as possible and trying to ensure that everything that you do is thought of for longevity. Class 4, another very challenging aspect in dentistry, as we have talked about. So I'll just run through some of the cases. And then here also you've seen this particular case, even if it's a small, even if it's a very different kind of a color, which you normally don't see, we can really recreate it into lifelike restorations. A patient who was going in for an ortho with a lateral incisor, which is fractured, we've recreated with the same kind of anatomy and also the hyperplasia, which is present on the contralateral lateral incisor, because we wanted to maintain that particular space when he went in for ortho. So there is no discrepancy in the space between the central incisor and the lateral incisor when the ortho treatment is completed. And as you can see from these post slides, how beautifully we have been able to recreate it, overlapping onto the central incisor like the other central incisor, so that the orthodontist does not have a tough time in knowing what the anatomy of the other broken lateral incisor is going to look like. This is immediately post doing it. That's the reason why it appears a little more higher value compared to the contralateral tooth. But after some time, you'll see that it looks fine. So in the layering technique, like in this particular case, as you can see, the first thing is to do a mock-up. Now we are living in a digital era wherein you can take a scan, if the tooth is central incisor is fractured, you take a scan, you digitally design it, and then you make a putty index of that and use that putty index to place your first layer. This is how you must use that putty index to place your first layer. First layer should start from the palatal surface, then you add your dentine shades, and then you come to your enamel shades, and then you're beveling with the translucent or whatever tints that you may want to do. This is immediately post doing it. After, then we mark the areas where the line angles are present in the central incisor to ensure that we recreate the same kind of anatomy as the contralateral tooth. This is a video, but I'll skip because of shortage of time. But this is how we try to recreate it. And this is the final result that we have been able to achieve on this particular patient. Absolutely lifelike. You see how beautiful those three lobes also we've been able to recreate. And this is the class 5 case which I had shown you earlier. This was what the canine was restored. As you can see from this blanching effect, there is an overgrowth of the free gingival margin which has taken place onto the lesion, carious lesion. So we had to do a little bit of gingivectomy, that is with laser, or you can do with electrocautery and with retraction cord. And you can actually see where the margin of your carious lesion is, and then removed all the caries. And this is how we have restored it. This is now there in the patient. We have a follow-up photo of this also. Has been there in his mouth for 10 years now, which is almost the same, except that we just had to polish it when he had come 7 years back. He works in Africa, and so whenever he comes here, we ensure that we polish his restoration. This is how the class 5 looks before. If you see that because of the caries, you see that hypocalcified area, that indicates that it is completely been eroded with caries onto the facial surface. Your margin is going to be way below, almost up to the halfway up to the canine. A close-up view of the same, where it will be almost impossible for you to make out where the composite is and where. So jumping from simple restorations to diastema closures. It's extremely important that in diastema closures, you understand the principles of smile designing. Diastema closure should only be taken. Ideally, the choice that should be given to the patient should be always ortho. If the patient refuses, or because of some other, like either they are getting married or someone else getting married, and they would want that to be done. And there are many reasons people want the diastemas to be closed. Then you have to remember that maximum that you can close a diastema is not more than 2.5 millimeters. Otherwise, the teeth will look very broad and it will not look good in the patient's mouth. Now, this particular diastema was just approximately 1.6 millimeters. So it was very easy for us to have the right ratio of the height to the width and ensure that it doesn't look artificial in nature. And this is one of the best things that we could have done for this particular patient. As you can see, even the blue translucency that is present on the incisal edge and which is extending into the mesial surface has been taken into the diastemas that have been closed. The lateral view of the same and the frontal view of the same also, the occlusal view for you to understand that how beautifully no overhangs, nothing present. Otherwise, that will be detrimental to the health of the patient. Normally, I would never take up such kind of a lateral incisor but a lateral incisor you can really get away. Such huge diastemas. This is a rotated canine. Ideally, we have told him, let me have some more. I'll take it up. We required the diastema to be closed. So we closed it in a lateral incisor also. An old patient who walked into a practice with some composites which are done somewhere else, posterior is missing and a crown which is present, says, Doc, I'm not going to extract this particular tooth. I already have a partial denture. I just need to look a little better with all the, please, can you help me out by removing all the scaries and the stains and everything. So this is how we did a transformation from this to this, increasing the length. You can see the incisal ledges, everything. I did not close the central diastema completely, others it would have really looked very ugly. I said this will at least look natural, even if this much of diastema that we have closed from before to after is good enough for her. So this is how she walked in and this is how she walked after. Another very challenging aspect of composite dentistry is to do direct veneers. And for that, you have to learn to make a tooth in composite from inside to outside. This is how I make people learn. First, you create a tooth in dentine. That means only the dentine part. If I show you the three-dimensional, unfortunately, I can't show you the video because of time does not permit us. So this is first the dentine layer. Then after that, the effect enamel, which has been added onto that on the facial as well as the palatal aspect. Then after that, we add the body enamel. Body enamel is the exact shade that you have selected for that particular tooth, starting from the cervical to the incisal edge, whether it is A3, A2.5, A2, A1, whatever you have selected. We start from the cervical coming right up to the incisal edge. And then after that, you do all the staining and glazing and polishing. And this is how I have recreated the whole tooth from inside out. Only if you learn to do from inside out, from dentine to enamel, is when you'll be able to give lifelike restorations in your practices. So let's look at 2 or 3 cases of direct veneers that we have come. This patient who walked into our practice after ortho treatment, suddenly she had to stop ortho treatment because she had to fly to the US. She had certain diastemas, though it was almost completed, the ortho, but still she couldn't go back. She had got a good job in the US. And so she said, Doc, can you help me out? And she had time constraints. So obviously I had to think of something which was direct composites, So this was in the pre-digital era, when we used to do a direct hand application of the composites. Like in this particular area of now dentistry that we are in digital era, you can scan this, you can design it, you can make you can print a tray out of it and you can use the bulk composite through a hole. Each and every tooth, you can do it in a single layer itself with a single shade. Or if the patient wants multiple shade, a little bit of staining later on after you have added each and every tooth. So this is the case which I started at almost about 10 in the morning and finished at 5 in the evening. And this is how we transformed the smile from this. As you can see, all the lateral tooth, even with the diastemas, the ratios of the height to the tooth, width, everything was wrong. But otherwise, the ortho was not done it was done very nicely. And this is what we changed the smile from before what she was to this. And she was going to fly in this 4 days' time. So you can imagine how beautifully her smile has been transformed. She was such a happy lady. She said that, Doc, this is going to really help me in my new job, which I'm taking up in the US. This is another case where it was an occlusal disturbance. We had to correct the occlusion, and he couldn't afford uh, uh, indirect restorations. So I have done it in composites by adjusting his occlusion and doing it everything in composite. And you see how beautifully we have tried. One of the most difficult things to do is the direct composites. And we have transformed his smile from this to this. A very manly smile. You can see his lips, huge lips, fully rounded, puffed, and it shows really well in his smile, you know. So success in dentistry is not based on aesthetics, but it is based on form and function. Focusing on form and creating natural tooth anatomy will lead to good aesthetics with longevity. It is imperative to understand the philosophy of tooth cycle for longevity of any dental treatment that is planned and executed. So, what are the changes and advancements that have occurred? Material science, there are nanohybrids and bulk fills available. Bioactive composites are available. Now there's self-healing composites which are available, which all the cracks that occur in the composites, they try and repair the cracks by themselves. Indirect inlays and onlays digitally designed in composites are an in thing nowadays. Digital smile designing transferred with silicon trays, printed and used along with bulk fill composites is what I just talked about when I showed the slides of the direct composites. Digital occlusion analysis is another area which is extremely. So, what are we looking at in the future in composites and digital dentistry? Nanorobotics for composite repair. Tiny robotic systems may soon be able to detect microfractures in the composites and repair them automatically. AI guided robotics placement on composite research is underway to develop AI assisted robotic arms for precise composite application. Bioengineered composite materials, future composites may integrate stem cells or bioactive agents for tooth tissue regeneration. All these are in the process of research which is going on. And I'm sure that in another 10 years, the scenario of composite dentistry is completely going to change. So, in conclusion, this combination of advanced composite materials and digital innovation is transforming restorative dentistry by enhancing aesthetics, durability, and longevity. And all this is making a line of treatment more predictable and minimally invasive. So we should be more conscious. I'll just skip this because so success is all about living footprints. Defeat is not the worst of the failures. Who has not got failures in their practice? All of us have gone through it. Anyone who stands up on us on a platform and says that I never had a failure is telling a lie. So its defeat is not the worst of failures. Not to have tried is the true failure. So you have to keep on trying all the new materials, everything new that comes out to try and succeed in whatever line. This is the kind of dentistry which I don't want you all to do or you all want to see. Please resist from this kind of dentistry that's there. We are going to be having once again, as we have had two successful international digital dentistry congresses. The third version is coming out here. It's on the 31st of May and 1st of June. I would request all of you all to register for this particular. It's going to be a real mega event, a very successful event. These are the speakers who have already confirmed. 16 are already the international and 38 I have already put up. The Indian ones on the screen you can see. So I would urge you, all of you all, to ensure that you'll register in bulk and come and ensure that you learn more than what you all have been learning or trying to understand. So thank you very much once again. Thank you, Dr. Rajiv. Thank you, Dr. Maya. And loads of thanks to LKP, Ramana, and Nagesh for making sure that this goes flawlessly and ensuring that things that are dear to them and ensuring that their students, their staff, and everyone is right up there in dentistry. So thank you once again. Thank you, everyone.
Thank you, sir, for a very informative session. Now the stage is open for question answer session.
Nagesh and Ramana, if there are, then you can forward it or you all can speak about it, or else, depending on the time, I leave it to Dr. Maya and Dr. Rajiv to decide whenever they want to close. Okay, so there is a question which was asked, a single shade composite. There are single shade composites which are available. All shades that are available are all single shades, whether it is A1, A2, but the only thing is that it depends on the translucency of the composite. That's the reason composites are available in the form of flow. They are available in dentine shades. They are available in enamel shades. They are available in translucent shades. The translucent shades also are available in different translucency. There'll be gray translucency, blue translucency, clear translucency, you name it, and there are different kinds of shades of composites which are available in the market. It's up to you to play around with the different kinds of composites that are there. And it's up to you to decide whether you want to buy a single shade and do it. See, it all depends on what kind of dentistry do you want to do. Do you want to do lifelike dentistry, or see, as far as posterior is concerned, I know that it is not so critical. But I would advise you all to start learning to do lifelike restorations in the posterior so that it becomes very easy for you all to give your anterior restorations, which are absolutely lifelike. Preeti Desai is asking, but I cannot read the full question. So can someone tell me what the full question is? They are asking, please unmute us.
Now we are unmuted. But
Okay.
the question was, recently new single shade composite available. How is it helpful to use in teeth with different color?
Okay. So now there are some composites which are available in the market, which are, there is a play of color in a single shade also. Like, I don't know, all of you all have heard about in indirect restorations. Have you all heard about the lithium disilicate now, which is available in multi-shade, They are known as multi-cat lithium disilicate, wherein the cervical part of it is a little yellow, then the middle is a little more brighter, that is, the value is more, and as you come to the incisal edge, it is more translucent. That's how the block of ceramic is available. So what they're trying to do is, when they use this single shade composite, they have added a multitude of shade in it, but the translucency is where you have to play around with. It's the dentine shade. Now, suppose if the amount of dentine that is lost is almost 1 millimeter, you have to place a dentine shade on that 1 millimeter and then play around with the enamel shades. If you just put enamel shades, then I'll assure you that your restoration is going to look translucent. It will not look lifelike. Because when light passes through and through that translucent shade, it'll appear as if it is grayish in color. I hope that answers.
There's another one for a wide class 1 cavity. Is occlusal bevel required?
Okay, in that I had mentioned that as far as the posterior is concerned, absolutely on the occlusal surface, bevel is total no-no. You cannot have bevel on the occlusal surface because of the occlusal forces. There are chances that during function, that thin bevel that you have recreated is what is going to break very soon during function itself. So extremely important, no occlusal bevel at all. Even though you may use a little bit of more enamel for adhesive purposes, but on the posterior, definitely not. In the anterior, use as much of bevel as you can to be in the enamel to ensure that your restoration lasts for a long period of time. So in class 2 composite, development of tight contact is difficult. How do you manage it? It's one of the biggest problems why people differ from using composites in the posterior region. That's why there are newer materials which are available in the market, wherein you have a clamp and you have a wedge and you have a ring, that is a ring, the wedge, and then you have a forceps which has got a spring inside it. So when you use that forceps with that ring and you open up that ring and you place it in between two teeth, that spring is going to transfer the forces from which is created by the spring enlarging and then closing into the ring, and it's going to bring about separation of the tooth And when you remove that wedge and that ring and the band, you will have a very tight contact.
So there's another question which says, can you recommend which would be the best company for composite materials in the world based upon the flow shade and chroma translucency?
Okay,
Like
there
to
is
recommend?
there are all the good companies that are available. I don't recommend any one particular company because I don't want to promote anyone. But all the brands, good brands that are available today in market in India are extremely good that are available. They are all good. Whether you talk about Densply, you talk about Evoclar, you talk about 3M, you talk about Kevo, you talk about all the products that are available are absolute quality standard. Is how you understand composites and how you start placing it, you will be able to do more lifelike restorations. As far
Also,
as the matrix systems are concerned, I prefer to use the V3 from Densply, which has been a very time tested, which really works very well in the posterior region.
I think that's all the questions we have.
Yeah, I think it's taken quite a lot of time. I hope that it's not.
Quite an extensive exercise you did. Thank you so
Thank
much,
you.
Deepak, for your very, very informative lecture. And I'm sure the younger dentists must have learned a lot. They have excellent faculties at their institutions, but this is your vast clinical experience, which I'm sure they'll all benefit from. I'm really grateful to you for accepting our invitation and coming and this presentation. And of course, from on behalf of PFA, we'll send you a certificate of appreciation. This certificate is being presented to you by the SIBAR Institute of Dental Sciences for your wonderful presentation.
Thank you very much. Thank you. I appreciate it a
Yeah.
lot. And
Maya
I
to
can see the crowd which is sitting in the auditorium. I'm going to say a big hello to everyone who's sitting there. And thank you for on a Saturday afternoon for sparing time and listening to me. And I'm sure that I hope that I have been some kind of a help to all of you all in understanding that why we should start saving teeth and not going for aggressive line of treatment the moment you see a class 2. So please remember, class 2's work, not necessary for you all to go in for full crowns.
Thank you,
Thank you,
sir.
LKP. Thank you, Ramanna. And thank you, Nagesh. Thank you, Maya. And thank you, each and every one of us who's present here.
Yes, sir.
Thank you, sir. Now I request Dr. Maya Ramesh, Secretary of Pierre Forcher Academy, India section, to deliver vote of thanks.
Perfect.
Dr. Maya.
iPhone unmute చేయడమా iPhone unmute చేయడమా iPhone unmute కావాలి రెండు ఉన్నాయి కదా I think for teaching
Happy and always being mentoring us and being present here today and giving a welcome address. And I would like to thank the guest speaker and former chairman. I would like to thank the guest speaker and former chairman, Dr. Deepak Muchala, sir, for his wonderful lecture. All his cases were wonderful, and I think he has magic in his hands. And thank you, sir. And I would like to thank Dean SIBAR Institute, Dr. L. Krishna Prasad, sir, and Principal SIBAR Institute, Dr. Venkata Ramana Reddy, sir, and Nagesh, sir, for the wonderful session. And I would like to thank all Senate members and fellows who participated in this. And I would also like to thank coordinators of SIBAR Dental College and participants of this continuing dental education program. Hope I was audible to you all.
Yes, yes, ma'am.
Yes, yes.
Thank you.
Yeah.
Thank you.
Thank you. Thank you very much, all. Thank you very much.
Thank you. Thank you. Goodbye. Thank you, Rajiv. Bye-bye.
Thank
Thank
you.
you, LKP. Thank you, Ramana.
Thank you
Thank you,
once
Nagesh.
again.
Yeah. Thank you, Ramana Reddy, sir. Thank you.
Thank you, Dr. Ramana and Dr. LKP, Dr. Nagend. Thank you.
Yeah. Thank you, Rajiv, sir. Thank you, Deepak, sir. Bye.
Thank you. Bye-bye. Bye-bye.
Bye.
Okay, lagi